Hello and welcome to our webinar today, a closer look at the 2020 MIPS program changes. My name is Michelle Brunson. I am a Health IT Advisor with Telligen for the Small, Underserved and Rural Support Quality Payment Program Resource Center. Joining me today are two of my colleagues, Kelly Smith and Tamika Williams. Our team assists small practices in Iowa, Nebraska, North Dakota, and South Dakota. Thank you for joining us to learn more about the Quality Payment Program changes for Year 4. Today we will cover the key changes for 2020 while mentioning what is remaining the same from 2019. We will discuss how you can build upon learning from Year 3 in 2019 so that you are prepared for a more robust Year 4 in 2020. We will also explore some steps you can take now to be successful in 2020. The nice thing about the final rule for 2020 is that much has remained the same. This is to allow you the opportunity to further refine and improve on what you have accomplished with the Quality Payment Program in the first 3 years. Along those lines, MIPS eligible clinician types haven't changed from 2019. They are listed here for your reference. Also, there are no changes for who is excluded from having to participate in the MIPS program. Those include clinicians at or below the low volume threshold criteria, which I will review shortly. The others include eligible clinicians who are newly enrolled with Medicare, as well as those advanced APM qualified participants and advanced APM partial qualified participants who choose not to report MIPS. There are also no changes to the low volume thresholds. You are excluded from having to participate in MIPS if you either bill less than or equal to $90,000 in Medicare allowable charges, or see 200 or less Medicare Part B enrolled beneficiaries, or provide 200 or less Part B services. There are 2 determination periods for the low volume criteria. Each period runs from October 1st to September 30th of the next year, with a 30-day claims runout. Segment 1 covers 10/1/18 to 9/30/19, and Segment 2 covers 10/1/19 to 9/30/20. The preliminary 2020 eligibility is available now on qpp.cms.gov when you enter your MPI in the MPI lookup tool. Final eligibility will be available around November 2020. This is applied at the submitting entity level, either individual or group. There are different provider populations that have special statuses for the MIPS program. CMS will automatically identify the eligible clinicians who are considered special status and will have them labeled as such when you look up your clinician's MPI on the MPI lookup tool found on qpp.cms.gov. Remember that if you see a low volume on any one of these three criteria I just mentioned, you will not be required to participate. Again, this will be shown under the MPI. You will see both an individual and a group label. If the individual label is grayed out, showing a circle with a line through it, you are not required to participate. The other special status populations include small practices and clinicians who are rural or HIPSA, non-patient facing, hospital-based, ambulatory surgical center-based, or facility-based, as well as those clinicians who experience extreme and uncontrollable circumstances. Details on how each of these is determined is in the final rule. We continue the same reporting options for 2020, either individual, group, or virtual group. Those details are shown here. Also continuing is the ability to opt in or voluntarily report your MIPS data. These 2 options are available to those clinicians who are not included in MIPS for any of those 3 low volume threshold criteria. The first option is to opt in. This option is available to those who meet either 1 or 2 of the 3 low volume criteria, but of course not all 3, as they would be required to report MIPS. If you opt in, you receive performance feedback, and you also receive a payment adjustment in 2022 for your score in 2020, whether that's positive, negative, or neutral. The second option is to report your data voluntarily. This can be done even if you don't meet any of the low volume criteria. You receive performance feedback, but you do not receive a payment adjustment. For both opt-in and voluntary reporting, once you choose the option in the data submission window, it is final and cannot be reversed. CMS has implemented a pretty substantial increase in the performance threshold, the level at which you would receive a neutral payment adjustment. They are raising the threshold from 30 points in 2019 to 45 points in 2020. This means that you will have to score a minimum of 45 points out of 100 to avoid up to a negative 9% payment adjustment in 2022 as a result of your score in 2020. The exceptional performer bonus for those high performers went from 75 points in 2019 to 85 points in 2020, moving that bar further to receive the exceptional performer bonus. Here's a graphic to display how the points scored in 2020 translates to the approximate payment adjustment given to all Part B claims in 2022. For example, if your points range between 45.01 and 84.99, you will receive a positive payment adjustment, but not the exceptional performer bonus. All of the MIPS performance category weights also remain the same. There is no change. Quality is still worth 45%, cost 15%, improvement activities 15%, and promoting interoperability 25%. In year 4, you will see the same performance periods required to be scored for the maximum number of points. Quality and cost still require a full year of data. The cost category is assessed through claims, so no data submission is required on your part. Promoting interoperability and improvement activities still require a minimum of 90 days of data, but up to a full calendar year can be submitted. Some improvement activities may require more than 90 days, so make sure to check the description. Now I'll turn it over to Tamika to talk about the quality performance category.
Thanks, Michelle. So let's get started into quality. As stated earlier, the quality performance category maintains a 45% weight. Key changes for 2020 quality performance. CMS has finalized the proposed rule to increase data completeness to 70%. So this just means that you must report at least 70% of your total patients who meet the measure's denominator criteria regardless of the payer. Clinicians in small practice, which is 15 or less in the 10, will continue to receive 3 points for measures that don't meet the data completeness criteria or requirements. Other key changes that we will look at in the upcoming slides are the 3 new measures for 2020. Note that CMS reduced the number of quality measures for 2020. There are now 218 measures in the quality category. 42 measures have been removed. We'll review those. There are 7 new specialty sets, so I'll list those out for you as well. And we will look at the new alternative benchmark policy and the measures that it applies to. One other thing to note that there are 83 quality measures that have changes. Data submission for quality to achieve your maximum points would be to submit 6 measures, and one of those measures should be an outcome measure. If an outcome measure isn't available, you would need to select another high priority measure. If less than 6 measures apply, you would need to report on each measure that applies to your practice. If you find it difficult to select 6 measures, remember there are measure specialty sets that catalog the applicable measures for you, and these are just to help you in selecting those appropriate measures. And again, data completeness threshold is at 70%. So if on any given measure data, your data completeness threshold falls below 70%, the maximum number of points you can achieve would be 3 points out of a possible of 10 for a small practice. And then also for 2020, the performance year, you can submit data using multiple data collection types, and that remains unchanged from 2019. Let's take a look at the new measures. So those 3 new measures that I mentioned, they are listed here on the screen. They're measure number 476, 477, and 478. These measures are high priority. Two of the measures are patient-reported outcome measures, and one is a process measure. Quality measures that have been removed in 2020. So calendar year 2020 policy for measures removed. Re the policy for those measures that were removed from the program has been updated. So MIPS quality measures that do not meet case minimum and reporting volumes required for benchmarking for 2 consecutive years may be removed. So that's what the policy now states. CMS will consider a MIPS quality measure for removal if it is determined it is not available for MIPS quality reporting by or on behalf of all MIPS eligible clinicians, and that's including third-party intermediaries. So there are 42 measures that are removed from quality reporting. Here on this slide, I listed a couple or a few that may be pertinent to some of the practices that we've worked with. And there are seven new specialty measure sets, and those are for speech language pathology, audiology, clinical social work, chiropractic medicine, pulmonology, nutrition and dietitian, and endocrinology. So, the alternative benchmarking policy. The policy in 2020 establishes a flat rate percentage benchmark in limited cases where CMS determines that the measure's otherwise applicable benchmark could potentially incentivize treatment that could be inappropriate for patients. The modified benchmarks will be applied to all collection types where the top decile for historical benchmark is higher than 90%. The two measures meeting that criteria would be diabetes, hemoglobin A1C, poor control, and controlling high blood pressure. So again, in 2020, the improvement bonus is available. In order to qualify for the improvement bonus, a full year participation is required. Comparison is only to the previous year data at the category level. If a previous year quality score is less than or equal to 30, then 30% will be used as your comparison. The calculation of the improvement bonus is done simply by subtracting this year's score from your last year's score and then dividing the score from the last year. This bonus is capped at 10% bonus points. And then with that, I will turn it back over to Michelle to discuss the cost category.
Thank you, Tamika. Now we will talk about the other category where one full calendar year of data is used, this time from the claims you submit. Let's dive into the cost performance category. First of all, let's talk about what remains the same. The weight is still 15%. By submitting your claim, CMS gathers the data they need to score your cost category. There are still two cost measures of total per capita costs and Medicare spending per beneficiary. Total per capita costs is assessing the total beneficiary costs during the year for Part A and Part B. Medicare spending per beneficiary is looking at the total beneficiary costs during hospital stays. This includes starting 3 days prior to the admission and up to 30 days post-discharge. This does exclude any unrelated services to that hospitalization, however. The case minimums for both of these measures remains the same, 24 total per capita costs and 35 for Medicare spending per beneficiary. Also, the 8 episode-based measures introduced in 2019 continue into 2020. Now let's talk about what has changed for total per capita costs. In 2019 policy, the total per capita cost is determined by the majority of primary care services rendered by the clinician. In 2020, the total per capita cost attribution will require a combination of the evaluation and management, or E&M services, and general primary care services, or another E&M service from that same clinician group. This revision of the total per capita cost measure attribution is very important, especially for practices that don't typically deliver primary care services, because CMS will exclude those clinicians that don't normally deliver primary care services, let's say surgery, or those clinicians who are in specialty practices that aren't usually responsible for patients' primary care, dermatology, for example. Attribution will be different for individuals and groups and will be further defined in the applicable forthcoming measure specifications set out by CMS. Now we'll talk about what has changed for Medicare spending per beneficiary. There is a slight name change in the naming convention. Medicare spending per beneficiary has been renamed the Medicare spending per beneficiary clinician to further define the term. There's a different term for Medicare spending per beneficiary for post-acute care, or MSPB PAC, and that can be confusing, so this helps clarify it a little more. Methodology has been adjusted for surgical and medical episodes. However, CMS has not published this data yet, so keep an eye out for it. Again, attribution will be different for individuals and groups, so watch for those measure specifications once CMS releases them in more detail. CMS also added 10 new episode-based measures for 2020 in the cost category. We have the 10 episode-based measures listed here. These, along with the 8 episode-based measures from 2019, equal a total of 18 episode-based measures that could possibly be used in your cost score in 2020 if they pertain to you. Review them to see if there are any relevant to your practice. They are categorized by procedure. Procedural measures are triggered by the major procedure with minimum case volume of 10 episodes. There are also 2 new acute inpatient medical conditions which are triggered by the E&M codes billed during the beneficiary's hospitalization. The minimum case volume is 20 episodes for these acute inpatient medical conditions. The services and associated costs are assigned to the episode if they are within the patient episode window, along with the clinician determination if the service is under the services of the attributed clinician. All clinicians and groups will be evaluated on the cost measures that can be attributed to you if they meet or exceed the measure's minimum case volume necessary for the specific measure to be evaluated and scored. If only one of the measures can be scored because that is the only measure which you surpass the case minimum, CMS will use that one measure to score your cost category. If you have 7 measures that can be scored, you will receive the equally weighted average of those measures. To calculate the cost score, CMS will give anywhere between 1 and 10 achievement points to each scored measure based on the eligible clinician or group performance, and that will be compared to the performance year benchmark, not the historical benchmark. If no measure can be scored, the cost performance category weight of 15% will be reweighted to quality, giving quality a 60% weight, 45% quality plus 15% from cost to equal 60%. Now I'll turn it over to Kelly to talk about the promoting interoperability and improvement activity performance categories.
Thanks, Michelle. As with the other categories, the promoting interoperability category maintains the same weight as it did in 2019, 25%. The category basics also remain the same. You can still choose to report for only a 90-day period or up to a full year. You are still required to use 2015 certified EHR technology, and a security risk analysis is required but not scored. Automatic reweighting for certain clinicians continues, and you are also able to apply for a hardship exception if you meet one of the listed criteria. There are 4 major changes to the PI category in the 2020 final rule. 2 changes from the 2020 rule go into effect in the 2019 performance year. The first is the e-prescribe bonus measure query of the prescription drug monitoring program, which will now be scored as a yes-no measure instead of on a performance rate. If you queried your state's PDMP at least once when prescribing an opioid and do not claim an exclusion for the e-prescribe measure, you can attest yes to this measure and receive 5 bonus points. The other change going into effect in 2019 is the policy for the reallocation of points if you claim an exclusion for the Health Information Exchange sending health information measure. If you refer less than 100 patients, you can claim an exclusion for this measure, and the points will be redistributed to provide patients access to their health information measure. There are also 2 changes in the final rule that will be implemented in 2020. These are the removal of the Verify Opioid Treatment Agreement bonus measure and changing the exclusion for the Health Information Exchange receiving and incorporating health information measure. This measure will now only have one option for exclusion. If you have fewer than 100 transitions of care, referrals, or new patient encounters, you can claim an exclusion. On this chart, you can see all of the promoting interoperability measures for 2020, their maximum points, and where the points are redistributed if an exclusion is claimed. The e-prescribing, health information exchange, and provider-to-patient exchange measures are scored on a performance rate with a numerator and a denominator. The query of the PDMP bonus measure and the public health and clinical data exchange measure are yes/no measures. Moving on to the improvement activities category. While there were changes to the improvement activity category, much remains the same. The category is still weighted at 15%. You can still choose to complete your activities in a 90-day period or up to a full year. Remember, some activities require longer than 90 days to complete. The points for activities will remain the same, with medium-weighted activities earning 10 points and high-weighted activities 20 points. Small practices and others with special status will continue to receive double points for each activity. Now let's look at the changes for the improvement activity category. One major change for 2020 is that when reporting as a group, at least 50% of the group must complete the activity you are attesting to. Clinicians within the group do not have to do the activity in the same time period as long as it is completed within the performance year. There are 2 new improvement activities for 2020 and 15 activities were removed. I will cover these more in a minute. CMS is discontinuing the burden study on quality measures, so this will no longer be an option for improvement activity credit. However, CMS is making it easier to have a patient-centered medical home designation for MIPS purposes by removing the reference to specific accrediting organizations. If a practice can attest to having a PCMH designation, they will receive full credit for the improvement activities category. Listed here are the 2 new improvement activities. Both are high-weighted, so small practices would earn a full 40 points for completing these activities. The first new activity is drug cost transparency. For this activity, you must attest to counseling patients about the cost of their prescription drugs and, if appropriate, explore alternative medications. The other new activity is using macro-relationship codes to track clinician relationship to and responsibility for the patient at the time of service. To attest to this activity, you must report patient relationship codes using the applicable HCPCS modifiers on 50% or more of your Medicare claims for a minimum of 90 days. CMS encourages providers to use these codes so patients and episodes can be properly attributed to clinicians. There are a total of 15 activities that were removed for the 2020 year. Listed here are a few key activities that small practices used in the past and are now removed. A full list of removed activities can be found in the 2020 final rule in Table C of Appendix 2. CMS is removing the registration in the Prescription Drug Monitoring Program activity because they believe simply registering in the program is not enough. They would like clinicians to consult and regularly use the PDMP and report activity IA PSPA 6. For similar reasons, CMS is removing the Initiate CDC training on antibiotic stewardship. This activity required clinicians to only complete 50% of the training, whereas IA PSPA 23 requires completion of the entire training. Since the TCPI program ended in September 2019, CMS has removed this improvement activity for the 2020 performance year. Finally, many of the activities that required use of a QCDR were removed because they're very similar to each other. 4 QCDR activities do remain. And now I'll turn it over to Michelle with some tips on how to succeed.
Thanks, Kelly. Okay, now we're going to try to pull all of this together to see how you might perform better and succeed in the MIPS program. First things first, understand the benefits of participating in MIPS as a small practice. CMS really wants to encourage small practices to participate in the quality payment program, and they do this in a number of different ways. First, you will receive double the points for the improvement activities with a special status. This means 15 points for submitting just one high or two medium weighted activities. You can take a hardship exception for the promoting interoperability category by simply filling out an online application before December 31st of the performance year, and then you don't have to submit any data for the promoting interoperability category. Those points are automatically reweighted then to the quality category. If you submit just one quality measure, you'll receive 6 bonus points. For every one of the 6 quality measures that you do submit, you will receive 3 points per measure. These 3 points are given even if you don't meet the 70% data completeness. And let's not forget, you still receive free individualized assistance from your technical assistance organization like Telligen. Now you can start by reviewing your past performance. This can be the best guide for the action plan moving forward. How did you perform in 2017 versus 2018? How do you think you will score in 2019? Is there room for improvement in any category? Since cost was first scored in 2018, did you receive a score up to 10 points for this category? You can review your cost score from 2018 to use as your guide to estimate your score. While 8 episode-based measures were used in 2019, at least it can give you a starting point. Next, for the quality category, it might be time to review the measures you do submit and if any are topped out, as they may be removed in the coming years. Start now by selecting others that might pertain to your practice. They may also be some new measures added, or perhaps you're choosing a new collection type, a way of submitting your data to CMS, moving from perhaps submitting your quality measures on your claims to using a registry or a qualified clinical data registry or QCDR. All of this can affect your plan moving forward, so make sure to enlist the free assistance of your technical assistance organization. For the promoting interoperability category, did you take a PI hardship exception for 2018 and/or 2019? Do you plan on doing so again in 2020? Or do you want to begin implementing the workflow for the measures where you had some issues? Have you done your own security risk analysis, or did you work with another organization to help you with that? Did you submit data to 2 or 1 public health or clinical data exchange and will continue? Or is now the time to do more research to find the best registries available for your specialty? And finally, with improvement activities, will you continue the same activity or activities? Did you verify the activities can be done again? Unless it specifically states it in the description, most activities can be done again every year. Just make sure to gather new documentation every year, of course. So let's start 2020 off right. First and foremost, work with that technical assistance organization in your area for free assistance. Next, understand the changes to the performance categories so you know how it affects your practice. Then get your entire team involved now. Use a team meeting to develop the action plan and your goal for your MIPS score. Talk about how you will update the team on progress toward that goal. If you are going to submit promoting interoperability data this year, begin working on that security risk analysis, your policies, and the mitigation plan for addressing the deficiencies found. Next, if you have an EHR, run an initial report for both your quality and your promoting interoperability categories. Share it with your team often. This will show the areas that have opportunities for improvement. Keep those lines of communication open with your EHR vendor. Were there any fixes that didn't get done in 2019 that caused issues? Where do those stand? If your reports were not showing data that you thought should have been there, bring it up with your vendor. There may be issues with their software, or you may not understand how or where to document in the EHR to get credit. Can they send you the workflow documentation? Then do you know your direct address? That's that secure email address in your EHR so that you can provide it to the referring practices when they reach out to your office for it. Along those same lines, do you know the direct address or secure EHR email of the practices to which you refer? Maybe you do, but it's not working as well as you would like it to. Can you contact someone at another office that you know to test sending a summary of care with them? More often than not, they need to practice too. Next, start the new year off by not only knowing which quality measures you'll submit, but by having your whole team document well so that you can meet that data completeness requirement of 70%. Run the reports often so you can make sure those measures you plan on submitting have data that you need. If they don't, go back to the vendor and make sure everything's working well. And then if re-education is needed for your team, do so. Cost is up next. Look at the fact sheet documentation from CMS when it's released to fully understand the new attribution and methodology. Look at those 10 new episode-based measures to see if any apply to you. And finally, if you do submit at the group level and plan to submit improvement activities, make sure everyone knows the activity they will complete and the plan. It doesn't have to be done at the same time, but at least 50% of the group needs to complete the same activity, if not the entire group. Well, that completes our tips for success. Please don't hesitate to reach out to your technical assistance organization often for free help along the way. Here are a list of the 2020 resources that are available now. CMS does a wonderful job of making these resources and continuing to update the list. So watch for those updates from them if you're on their listserv on qpp.cms.gov, as well as from Telligen in our monthly newsletter. Thanks again for listening to our webinar. Our contact information is here for you to reach out at any time. We would love to hear from you. If you aren't from Iowa, Nebraska, North Dakota, or South Dakota, we can help you get the technical assistance organization for your state for the best help. Thanks again and have a great day.